very slow, and
Okay.
we will try to get use of the time, please. Go ahead.
The topic for today is GI bleeding in the newborn, how to diagnose, manage, and when to escalate.
Please raise your voice and be as slow as possible, without being monotonous, of course. Just unstress on the important words, important sentences, important articles. Okay.
Okay. GI bleeding in the newborn, how to diagnose, how to manage, and when to escalate. It's a practical approach. Today's approach will include an introduction, what makes this topic important, recognizing the different manifestations of GI bleeding in the neonate, differentiating benign versus serious causes, and we'll also highlight the most important points in the most common causes. We'll give a brief hint about the less common ones, and then we'll talk about the initial clinical approach, including investigations, lab work, imaging, and management. The learning objectives for today is recognizing clinical presentations of GI bleeding in the newborn, differentiating between benign and life-threatening causes, applying a stepwise diagnostic approach and investigation plans, managing the bleeding based on severity, source, and systemic signs. First of all, why this topic matters. Well, this topic is not that common in the newborn, but it can be very, very alarming. And it usually can be very benign or very life-threatening at the same time. So a very thorough investigation and prompt intervention is required. Early recognition and structured thinking can really save lives in this topic. The exact incidence of different factors is not really clear, but what is clear is that NEC incidence in very low birth weight infants is 7 to 10%. The second one is vitamin K deficiency is 0.25% in newborns that did not receive vitamin K. And cow milk protein allergy is between 2 and 5%, but unfortunately the incidence is rising due to the use of formula feeds. A quick warm-up question كده in the chat كده كل حد يكتب إجابته. The question is, what is the most common cause of rectal bleeding in a healthy newborn infant? بسرعة كده بس كل حد يدي الإجابة فكرة هتطلع إيه؟ شايفين سي بي سي 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 دي سي تمام سي.
يعني ممكن تكون سي يا عبد الرحمن.
تمام، هي اغلب الناس جاوبت سي فاغلب الناس صح، هي سي. تمام. وده الحمد لله a very benign cause، بس في نفس الوقت مش معنى ان احنا يعني take it lightly. A quick anatomical definition كده وريفرشر. احنا بنفرق ال upper GI bleed versus the lower GI bleed
in English
versus the lower GI bleed depending على the proximity or how distal it is from the ligament of Treitz. What's proximal to the ligament of Treitz? It's the mouth, the esophagus, the stomach, and the duodenum. What's distal to the ligament of Treitz includes the jejunum, the ileum, the colon, and the rectum.
So the ligament of Treitz divides the duodenum. So there is a proximal part, a distal part.
Yes. The manifestations of GI bleeding, we can divide them into upper GI bleeding and lower GI bleeding. In the upper GI bleeding, we can see we have hematemesis, which is vomiting of fresh blood, yani red blood, which differs it from coffee ground vomit. Coffee ground vomit is more of a digested blood, and we can see in the picture here, it's very different from fresh blood. Melena, which is black utari stool in this picture down here. On the other side, we have hematochezia, which is profuse rectal bleeding, fresh bleeding per rectum, like the picture over here, or blood-streaked stools, or mucus plus blood in the diaper.
There is a very important presentation of GI bleed, lower GI bleed, which I like you to refer to, Dr. Abdelrahman, which is the occult blood in stools. And I don't know if you prepared this.
Dr. Ahmed is on. Dr. Ahmed Fouad is on.
ازيك يا دكتور احمد، مشرفنا ومتأنسين بيك we didn't do a lot. We are waiting for you to enrich our discussion. Thank you very much for attending. Appreciate.
أهلا بحضرتك، أهلا وسهلا، فرصة
Uh,
سعيدة جدا والله.
you are free to comment or
أوكي.
stop us at any time, correct, comment, add a new information. It's this is the area of your expertise, and you are here to help us. Thank you very much.
Okay, you're welcome. Thank you.
We were talking about occult blood in stools, Dr. Abdelrahman.
I didn't really refer to occult blood in stool. I focused more on overt bleeding.
Sorry?
I focused on overt bleeding more than occult blood. Overt bleeding.
Occult blood is a form of GI bleed when the amount of blood is not that much. And when you suspect GI bleed, especially if you have a baby suspecting of cow milk protein intolerance, you might look for occult blood. And occult blood in the newborn might be different from other infants or older children or adults. Because initially, the baby passes meconium. And if you check meconium for occult blood, it will become positive. So you have to be careful about that. Keep going.
Okay. Next, we have a very quick diaper quiz. If everyone of us can guess what picture A is, and B and C. We have 3 pictures. Which one is Melina? Actually, we have a lot of different answers. But the first one is normal meconium. The second is blood-streaked stool, and the third is melena. You can tell this is meconium. It can be a bit confusing because meconium is dark and sticky, but it's green. You can see on the periphery right here, it's green. While melena is usually a lot more sticky, a lot more black, and it's a bit more gelatinous.
You refer to blood-streaked stools, which is important. When you have a well-formed stool with a streak of blood, you might think of anal fissure. But if the blood is homogeneously mixed with the stools, you think of a real bleed, up GI bleed or lower GI bleed, mostly lower GI bleed. Okay.
Okay, now we talk about
عاوز بس أقول كومنت هنا إن البيكشر نمبر E الانفانتس اللي هم اون امينو اسيد بيزد فورمولا او اكستنسيفلي هيدرايزد فورمولا ممكن يعملوا جرينيش بلاك ستول، بس طبعا هيبقى يعني ليس فيسكس عن الميكونيوم كده، لمجرد بس ان هم بياخدوا امينو اسيد او اكستنسيف هيدرايزد فورمولا. ده ساعات بيبقى كونفيوزنج، الناس بيفتكروا ان دي ميلينا.
Yes.
نقطة مهمة لازم نبقى عارفين ان الطفل
Yes.
بياخد امينو اسيد بيز فورم هيعمل ستول
Should
ممكن
know
نفتكره مونينا.
what is the baby fed, so we can interpret what mom is finding in the diaper and if it's concerning or it's something physiologic or benign. Thank you, sir. Thank you very much.
دكتورة منال عبد الجواد معانا برضه يا دكتور إيهاب.
أهلا وسهلا. You are more than welcome.
أهلا بحضرتك يا
I'm
فندم.
very happy.
السلام عليكم.
I know you
السلام.
go to bed early, so
أيوة صحيح.
we mean at 9 o'clock you attended. But the 8
هو بس العيشة لسه ما أذنتش، وأنا والله للأسف يا دكتور إيهاب كل يوم سبت بيبقى عندي ميتنج للليفر ترانسبلانت الساعة 9، فعشان كده أنا مش بقاش يعني بيبقى حظي سيء جدا إن أنا مش بقدر أحضر معاك.
Can have you for 1 hour each Saturday and then you can switch to the liver transplant. We appreciate your attendance and thank you very much.
You are welcome. الحمد لله إن قدرت أحضر معاكم.
Thank you very much. تفضل
Sorry
تفضل.
for interruption. You should continue.
No. We are happy with having you with us. كمل يا دكتور.
Okay, we're gonna start now differentiating the causes between benign causes, and these, if isolated, should be reassuring, and serious causes, red flags. Among the benign causes is swallowed maternal blood, anal fissure, and certain presentations of cow milk protein allergy in a well baby. In some of the very serious conditions are necrotizing enterocolitis, vitamin K deficiency, sepsis with DIC, volvulus with obstruction, Hirschsprung's enterocolitis, and stress gastric ulcers. We can also differentiate the causes between local and systemic. The local ones, you will see that most of the local ones are benign, like all the benign ones are in the local section.
Cause. You mean
Local
local
to the GIT
cause.
tract.
You mean local cause for bleed and versus
Systemic cause for bleed, yes.
yes, a systemic.
Extends beyond the GIT tract.
Yes.
So the benign causes we can see are both in the local causes, under the local causes, but also we have some of the more serious ones, like necrotizing enterocolitis and gastric ulcer. Systemic causes are ones that usually all of them cause a type of coagulopathy. That's what they all have in common, like vitamin K, sepsis with coagulopathy, congenital clotting disorders, liver failure, or DIC for any other cause. Less common but important causes, like if you went through your examination and investigations and you couldn't rule out from the more common ones, we need to keep these in mind, but they're quite uncommon. AV malformations and neonatal hemangiomas, like persistent bleeding or unexplained bleeding. We have normal labs. Think of AV malformations, structural abnormalities like esophageal duplication cysts. These can have abnormal cells that can produce gastrine and gastric acids. They can lead to ulcers, intestinal duplication, and you have infections.
I have a little comment on the causes.
Oh.
Because I know that you already added the gastroesophageal reflux, and I asked you to get rid of it, but I will add some comment on the gastroesophageal reflux. Usually the scenario for a gastroesophageal reflux causing reflux esophagitis and upper GI bleed and maybe failure to thrive. Usually the scenario is you have a preterm infant and baby corrected age is around 37, 39, and the baby is on formula, and this baby will start to have reflux manifestations and then might have an upper GI bleed. The reflux could be a problem on its own because of prematurity and other factors. We are not discussing reflux now, but it could be also secondary to cow milk protein intolerance. And it can present with upper GI bleed. So I just want to add this because I asked you to get rid of this. I'm sorry, Dr. Abdelrahman.
No problem. Okay, now we're gonna highlight some of the most important and common causes and say a few words about each. The most important one and the most common one will be swallowed maternal blood. It's a harmless imposter. Usually presents in day 1 or day 2 of life. Hematemesis, the baby has to be well. Look for a breastfed infant and ask about nipple cracking, and look for vaginal delivery. More chance of swallowed blood during vaginal delivery. The baby should be stable, no anemia, and we do the APA test. We'll talk about this in detail further down. Also, always check for anal fissures.
Any breastfed baby who has who is spitting blood and you're suspecting it's a maternal blood, you should examine the breast of the mother. You should. You ask the mother and know how she's feeding the baby. Is she having any pain during the breastfeeding? And then you go and examine the breast of the mother. There might be small cracks or sores or fissures, and this could be the source of the blood, and this will make the diagnosis and will not need to do any more other sophisticated investigations.
Okay. Next, we have anal fissure. It's very commonly overlooked. People always forget to check the genitalia and check the anogenital region, but it's very, very important to check for anal fissures. It usually have a bright red stool on the stool surface at the very end of the stool. The baby will also be well with no systemic illness. It's due to constipation, hard stools, or aggressive wiping. Just visual inspection will usually grant you the diagnosis on this one.
I have a very cunning question for you, Abdelrahman. What if the baby has multiple anal fissures?
Multiple anal fissures?
And what should you do? It could be secondary to constipation, like single anal fissure, but you have to be very cautious. Sometimes this is the one unusual presentation of Hirschsprung disease, and you have, if the baby, if you do like an X-ray or gastrographin, and this confirms the diagnosis, you need to do the manometry or the gold standard, which is the rectal biopsy.
I honestly was thinking more of child abuse.
Child abuse? A newborn with multiple?
It was, we've seen it. It's been seen.
I don't know, but this is very, very unusual.
Mm.
I never heard of it. I know about child abuse. It's very common in the United States, but I never mind. Keep going.
Cow milk protein allergy. Cow milk protein allergy has a lot of manifestations, a lot of different kinds of presentations. It could be IgE mediated, non-IgE mediated, or mixed. The very relevant subtype for us today would be a non-IgE mediated form called food protein induced allergic proctocolitis.
Dr. Ahmed, if you don't mind, because there is a lot of nomenclature in this field, and that might be a source of confusion. We have cow milk protein allergy. We have food protein
induced proctocolitis.
colitis.
Oh.
We have cow milk protein allergy. We have eosinophilic colitis or esophagitis. Are they the same or under the same category, or they are different? And if different, what is the difference? Because this is confusing.
هو حضرتك الكاوز ميلك بروتين الرجي من ضمن برزنتيشنز بتاعته انه ممكن طفل يجي بفود بروتين انديوس بروكتوكولايتس، وده مش اكسكلوسيف للكاوز ميلك، ممكن يحصل مع الفود مع اذر فود الرجيز. بس طبعا الكاوز ميلك
ممكن
مع الصويا وممكن مع الايج الرجي، بس هو طبعا بيبقى مور كومن مع الميلك الرجي. لكن موضوع الايزنوفيليك كولايتس اتس اسورتو من كاو ميلك الرجي اللي هو بيبقى مور سيفير، ونسمي هنا الميكانيزم بيبقى ميكسد. يعني هنقول ان مثلا زي الفود بروتين اندوست بروكتوكلايز ده نون اي جي ميديتد، ومثلا الانجيوديما واورال الرجي سيندروم دوت اي جي ميديتد. في نوع ثالث بنسميه ميكسد، بيتسمى احيانا الرجيك او ايزينوفيليك كولايتس او اسوفجايتس او جاسترونترايتس، وده كاتيجوري لسه مش ويل ديفايند قوي، ولسه طالع له يعني كرايتيريا جديده، نومنكلتشر جديده في الاسباجان.
I know some people when they suspect problem with cow milk protein intolerance or colitis, or they order for eosinophils in the stools and check CBC and F in the blood to see if there is eosinophilia. I don't know how appropriate
هو ممكن يكون في ايزونوفيليا في الستول، لكن غالبا مش هيكون في ايزونوفيليا في البريفرال بلاد.
اوكي.
حتى في الحالات اللي بنسميها ايزونوفيليك يبقى بريفرال ايزونوفيليا around 25-30% بس.
Okay, sir. Thank you very much. Abdelrahman, keep going.
Okay. As we were saying, the relevant subtype for today is food protein-induced allergic proctocolitis. It's non-IgE mediated, it's the most common phenotype causing bloody stool in neonates. The typical clinical picture, it appears in the first few weeks of life. Babies also will be well appearing and thriving. And we have intermittent blood streak stools, not frankly bloody stools, not voluminous blood, but just streaks of blood. Occurs in
Is it associated with mucus also?
Could be associated with mucus.
لازم يكون في mucus.
What is the significance of mucus? When you have mucus in stools for any person, any age, what does this mean?
So just inflammation.
Colitis.
colitis.
It means colitis.
خد بالك يا برضه عبد الرحمن ان معظم البيبيز والسمول انفانتس بيبقى دايما الستول السريكد بلاد دايما بيبقى انترميتنت، وده للاسف بيبقى ساعات ديسيفنج للامهات. يعني تقول انا النهارده شربت لبن ظهر دم، بكره شربت وما ظهرش دم. ده ساعات بيخليهم مش كونفينسد قوي ان ده بسبب الميلك الرجي.
diagnosis نفسه.
اه
هنا occur في exclusively breastfed infant ممكن، بس طبعا a lot more common في formula fed infants.
لا،
usually no
هو
fever.
هو مور كومن في البريست فيد
Yes, but not exclusively.
بس نوت اكسكلوسيف، يعني اكتر في البريست فيد.
Yes, and because mom is consuming dairy products, you have to add this sentence. Mom is consuming dairy products. This is important in the history. And or formula, of course, formula. And the important point is that soy-based formulas can cause the same problem in 25% of cases. So when you have a baby, as you are going to discuss the management later, but don't describe the soy-based formula for those babies. This is the important part.
الكروس رياكشن هيبقى حوالي 50% ما بين الكاو ميلك الرجي والصوي الرجي.
Yeah, yes. Okay. Wait, go back,
Yeah.
please.
Oh, okay.
You mentioned no vomiting, fever, or systemic illness. I just told you the scenario.
The protein induced proctocolitis مش في other presentations.
Oh, so you are not talking cow milk protein allergy in general?
لا,
or
induced allergic
intolerance?
proctocolitis only.
Oh, you're talking proctocolitis. Because cow milk protein allergy can cause reflux, as I told you initially. And reflux, if it's for some time, usually we see it in preterm babies because it needs some time to develop and cause the bleeding from gastritis. It can cause upper GI bleed. But we don't see this in term babies because it needs time to develop. But in preterm babies, they are with us. They are kept in the NICU for more than maybe 2 or 3 months, sometimes depending on how premature is the baby. So they can bleed, spit blood, have reflux, and they can spit up. They can have vomiting. So if you are talking proctocolitis, yes, it is lower GI. Correct.
ساعات كمان دكتور إيهاب الأطفال هم الفول تيرم على سن مثلا شهر ونص كده، ممكن لو عندهم كاو ميلك ألرجي يجوا بهيماتيمسز نتيجة جاسترايتس.
Yes, sir. Yes.
أكتر من الريفلكس في السن الصغير.
Yes, sir. But it usually takes time. Yes.
Okay.
Keep going.
Yes, sir.
The next topic is vitamin K deficiency. Vitamin K deficiency has 3 forms usually. Can be early, classic, or late. Early in the first 24 hours, late from 2 to 7 days, classic from 2 to 7 days, and late from after 2 weeks. Usually the mucocutaneous bleeding occurs more with the classic form than any other form, but it can occur, of course, with all forms. And it usually presents in a well-appearing infant born at home, did not receive vitamin K. The history can be very telling in this case. And it usually has an oozing umbilical stump and can be bruised as well. So, as we said,
the baby may be very sick because
be very
vitamin
sick.
K can also cause intracranial bleed.
Could be, yes.
And it could cause bleeding anywhere in the body.
That's why it's a very important topic.
GI. And it's very important because we have many home deliveries in Egypt. And I don't think for home deliveries they give vitamin K. This is extremely important point. So if you are a pediatrician working in the Ariaf and you see babies, you have to give them vitamin K. Please don't forget that. You could save their lives. Okay,
Okay.
keep going.
As we said, it happens with more in exclusively breast infants with home birth because they miss the vitamin K prophylaxis. We do a coagulation profile. PT is prolonged, PTT is prolonged, but with a normal platelet count. Giving vitamin K is life-saving in this case. Now to necrotizing enterocolitis. It usually occurs in with different instances depending on the gestational age. In extremely preterm infants, less than 28 weeks, it usually occurs around 3 weeks.
Be careful, it is a disease of prematurity.
It's a very,
Sometimes it can affect a term baby, but it is
it's rare.
like RDS, it is a
Oh.
disease of prematurity.
When it affects the term baby, there's significant risk factors involved. It's not a routine thing we see. In moderate to late preterm infants, within the first 2 weeks, in term neonates, it's a lot more rare, but usually we see it with perinatal asphyxia. Typical clinical features in a premature infant: he started feeding, distended belly. You have some of the vague signs. Apnea is very common to happen. Bloody stools is not that common to happen. Usually they develop constipation and they stop passing stools altogether with a distended abdomen. You do standing up the
You
serial
said
distend.
it's not common?
It's not common. It's a late sign.
It is a rare
Late.
It could be early, it could be late, but it is
Oh.
one of the main features of necrotizing enterocolitis to have bleeding per rectum.
Of course it is, but it's not the first sign we usually see. I'm just saying takes a bit more time to happen.
Sometimes it is the first sign. Never mind, we are not going to discuss necrotizing enterocolitis.
We do serial abdominal X-rays. We see pneumatosis intestinalis. We see portal venous gas. We see sentinel loop. We see fixed loops. We can do ultrasound. It's a new thing we do with the Fein Gold protocol. We can see wall changes, free fluid labs. A new lab finding is the fecal calprotectin. We also do an ABG. We find metabolic acidosis, hyponatremia, thrombocytopenia. That's the classic triad we usually look for. Modified Bell's criteria is very useful. It's the only staging and it helps standardize the care and diagnosis.
What is the main problem pathognomonic of necrotizing enterocolitis? Go back to the last slide.
Okay.
Which one of the typical clinical picture is the pathognomonic of pneumatosis? Sorry, I said it. It's pneumatosis.
Pneumatosis intestinalis, you mean on the X-rays?
Pneumatosis, yes, in the X-ray. Keep going.
Stress-related GI bleeding, stress gastritis. This is in a very sick neonate, usually ventilated, post-operative or hypoxic. Presents with hematemesis. Increased risk if they're on steroids. We usually start IV proton pump inhibitors if we suspect a GI bleed in an unstable neonate. Hirschsprung-associated enterocolitis. We suspect this if it's a known Hirschsprung's case, or if it's under investigation. You have delayed passage of meconium, which for 48 hours. You have distension, fever, foul-smelling diarrhea, bleeding. There's an increased risk of perforation and shock. Management is rectal irrigation, antibiotics, and of course, surgical consultation. Volvulus. Volvulus usually presents honestly with bilious vomiting before it presents with bloody stools. But it could also present with bloody stools. Baby would be rapidly deteriorating at that point, and it's a surgical emergency. We're going to talk about more about like history and physical examination in detail. Starting with the history, we always have to start with the maternal history. We have to ask about maternal medications because some medications can increase the risk of vitamin K deficiency, like warfarin or anti-epileptics, some antibiotics, but rifampicin isoniazide. Infections in pregnancy can affect liver functions sometimes, like CMV, herpes simplex. Coagulopathies or thrombocytopenia can be inherited, like HELLP syndrome or ITP, lupus. Also, we have to ask about the maternal diet. We talked about this. When having a diagnosis of common protein allergy in mind. Bleeding during delivery. If there was a huge amount of bleeding during delivery, we have also asked about the placenta. Was it the placenta was abrupted? Was it a CS section delivery? Was it a vaginal delivery? This can all lead to more swallowed blood during delivery. Perinatal and delivery history, gestational age. As we said, with decreasing gestational age, there's an increased risk of neck, and term babies are less likely to have neck. The mode of delivery, we talked about that. Delayed cord clamping. Delayed cord clamping will not directly cause GI bleeding, but it affects the labs. It affects the hemoglobin levels on your CBC, so it can cause some misdirection. Umbilical catheterization can, like, on long-term risk, causes varices, but we won't really see that in the NICU. Vitamin K.
We can see varices in the newborn baby if there is a liver problem, severe liver problem, liver failure.
I mean, related to the umbilical catheterization.
Yes, but the catheterization usually will lead to portal hypertension later on in infancy, but not in the, most probably not in the newborn period.
Vitamin
K, as you said.
Vitamin K administration. It's very crucial to ask, was it given, was it not given, what was the route, the dose, and always check if it was given, and if there is any doubt, you can always give it again. Neonatal history, day of life. Presenting on day 1 or day 2 of life would point more to swallowed maternal blood, early sepsis, vitamin K deficiency. Going more forward, we think more about common protein allergies, we think more about necrotizing enterocolitis, infections. Feeding history, very important, as we said, for cow milk allergies, neck, and GERD. The stool pattern, we ask, is it melena? Is it hematochezia? Is there mucus? Is there no mucus? Vomiting, bilious obstruction. If there was a history of bilious obstruction, we can pick more about volvulus. Vital signs and perfusion. This is a must with every single baby. You have to go with A, B, C, D. Recent NICU interventions can put the baby under stress if there was a nasogastric tube installed, and a full sepsis workup for if you're suspecting sepsis. Examination.
عبد الرحمن ممكن أضيف حاجة بعد إذنكم؟
اتفضل يا دكتور طبعا.
هو very important note موضوع الأمبلايكال كاسترايزيشن ولو حصل منها بورتال فين ثرومبوزس. هو زي ما تفضل الدكتور إيهاب وقال إن الهيماتيمسيس هيحصل بعد كده في الانفانسي. هو فعلا الفيرست برزنتيشن اوف امبلايكال فين ثرومبوزس وبورتال هايبرتنشن وبورتال فين ثرومبوزس وبعد كده لما يحصل كافيرنس مالفورميشن وانكريز البورتال فين بريشر، فعلا الفيرست برزنتيشن بيكون هيماتيمسيس واول اوف صادم واكيوت، بتبقى يعني حاجه مخيفه جدا ومرعبه. ولما بناخد الهيستوري بنعرف بقى موضوع الامبليكال كاسترايزيشن اللي كانت في النيوبور. بس حبيت اوضح حاجه.
Thank you very much. Very good win, actually.
Examination. Seeing if the baby is well versus unwell is the main point at the beginning before anything else. You have to assess whether this baby needs an urgent intervention or can wait for a bit. So we look always at the general appearance. Is the baby sick? Is it
Can you
well?
illustrate more, Abdelrahman? Can you go more in details?
I will go into the details.
Sick versus well baby, and how we can detect the amount of bleed is like insignificant, mild, moderate, or severe, based on the clinical picture.
Oh, now we're going to go into detail right now. Yeah, the
Okay.
general appearance of the infant. Is he sick? Is he if he's sick or not? The tone. Is the baby a floppy infant? Totally not there. Floppy, pale. The vital signs: heart rate, capillary refill time. What are they? They can also give you, and the blood pressure, of course. The abdomen, you can look at the abdomen. Is abdomen distended? Is it tender? Is there bowel sounds? Is there discoloration? Of course, if there's a tender, hugely distended abdomen, that will always point to something more surgical. If the baby has a very high heart rate, poor perfusion, capillary fill time is not well, blood pressure is not well, we can also ask the mother if they've been a long time at the house about the urine output, how many diapers have been changed on that day. That can give us a very good idea about the urine output of the baby and their fluid status. But if the baby is generally well, they've been feeding, their color is good, their tone is good, vital signs are all right, we can go into more deeper investigations and look for our benign causes. And a note here is that not to take the amount of blood as a guide. Like I would usually ignore the amount of blood because a parent seeing their child bleeding at any moment in time will cause panic, either if it's a drop or if it's a bucket. So be more guided with the baby's clinical condition rather than the description of how much the blood was actually, because they can be very misleading sometimes. Also, don't forget to examine the mother, as we said before, the breast for cracked nipples or bleeding. As I was saying, talking to the parents in the case of hemorrhage is very important and should not be taken for granted. Because as I said, they will panic either way. It's a baby, they could have been born for hours or a few days. They want to change the diaper and it's full of blood. So don't be not confident, don't take it for dismissive. Like we already know that the most common causes are probably benign. That doesn't mean we should take this lightly, it should be taken very seriously. And what's said to the parents should be very measured. A few points about nasogastric tube and aspiration of the gut contents. It was recommended before to do nasogastric aspiration for residual feeds back ago. It's historical now. To look for how much of the feed is remaining. Is there coffee ground? We would look for bilious aspirate. And sometimes people do nasogastric lavage when they suspect upper GI bleeding to confirm the upper GI bleed. But recent evidence have shown that it's not reliable. It yields a lot of false negatives, and it's invasive, and it's actually more harmful than good. Especially in sick preterms. In sick preterms, the insertion of the nasogastric tube can actually cause iatrogenic trauma, and it can lead to perforation. So it's better avoided most of the times. The only times we actually need to do it.
A high false negative
a false negative rate, very high.
result, which can mislead you.
Oh, yeah,
Yes,
okay,
yes,
100%.
yeah, we see it here. Great. Yes.
When we might do it, we might do it if there is massive hematemesis in a stable baby, which is not that common, and we're preparing for endoscopy. Or if the baby is intubated and he has a known upper GI source bleed. So you're doing that to measure their output. A quick MCQ break. We can all answer in the chat your question. And then a 2-day-old term neonate presents with 1 episode of bright red hematemesis. The baby is well appearing, feeding normally, has stable vital signs. What is the best next step of management? A, perform a gastric lavage to confirm an upper GI source. B, withhold feeds and prepare for surgical consultation. C, observe and consider non-invasive diagnostic testing. D, start broad spectrum antibiotics. Or E, an urgent upper GI endoscopy. C. Okay, everyone got it correct again, alhamdulillah. It's C, observe and consider non-invasive testing. The baby is well, he's feeding normally, has stable vital signs, and only has 1 episode. So we should follow up and see. Laboratory and imaging. So we start our workup, CBC. It's a case of bleeding. CBC, we look for anemia, we look for thrombocytopenia. Coagulation profile, we look for PT, PKT, the INR, the D-dimer, could be vitamin K deficiency, could be liver failure, could be DIC. The CRP and procalcitonin, inflammation, sepsis, always has to be a differential in the NICU. Liver function test, well, as we said, we have some infections that can affect liver functions like CMV. We look for the synthetic function, portal hypertension, however rare it might be. Blood gas and lactate. If it's shocked or NIC, we usually have metabolic acidosis. We'll also look at the diaper. In the diaper, we have the APID test. We have fecal occult blood in stool, Dr. Ehab said earlier. Fecal calprotectin. And if available, but it's not available here, PCR if you're looking for infectious colitis. But a note here, if someone has PCR, during infectious colitis, they found that a lot of neonates have Clostridium difficile colonating their colon, so it was misleading for some people.
Yeah, it
Abdelrahman,
is. Like
Dr.
37% of neonates have their gut colonized with the C. diff. So if unless the baby is very sick and actually looks like pseudomembranous enterocolitis, you don't have to care about this positive stool sample, because it is false positive, not false positive, it is just colonization.
They said it was a non-toxic variant of the bacteria, not causing any toxemia.
كنت عاوز اعلق هنا على موضوع الكالبروتكتين.
اتفضل حضرتك.
هو هيتكلم عليه بالتفصيل يا دكتور احمد، اعتقد مش
طيب
كده؟
خلاص
لسه ليها.
خلاص اجل الكومنت بعد ما نخلص.
تمام.
وانا برضو I have comments about it. Let's
بس الابيد تيست is very important. ده بندفرنشيت fetal versus maternal blood in emesis or stool. الميثود بنقاد صوديوم هيدروكسيد to blood sample، ده في المعمل طبعا. لو الفيتال هيموجلوبين بيكون resistant بيفضل pink، لو المذر بيقلب brown. best for well baby early hematemesis. الcaution اللي معاه بس we do not store the sample. We took the sample, give the sample to the lab. If it's sitting around for a long time, it can lead to a lot of false results. Calprotectin بقى. Calprotectin, it's a new marker they're looking for in necrotizing enterocolitis. It has not been incorporated in any guidelines yet, but it's yielding some results. What is fecal calprotectin? It's neutrophil protein released during mucosal inflammation. Why they find it useful in necrotizing enterocolitis? Because it helps predict the probability of necrotizing enterocolitis if you're questioning it before the baby becomes clinically deteriorated over the next 2 or 3 days. They found they have great sensitivity and great specificity of 86% and 93% respectively. But the drawbacks, unfortunately, are that most labs will not have fecal calprotectin, and they could not find cutoff points for preterms because they found they have baseline elevations, and it differs also with their gestational age. So it's very hard to find a reliable cutoff point. But sometimes in Europe, they're having point of care calprotectin to try and shorten the time to get their lab results. But over here in Egypt, if we give it out to an outsourced lab, we'll usually get the results back in 2 days, which would defeat its purpose altogether.
Yeah, this was my comment. If you think it is a good detector of early or starting or possible neck in a preterm infant, and then it will take 3 to 5 days to get the result. So this eliminates its value. This was my comment. دكتور أحمد حضرتك اتفضل.
هو كمان الكومنت بتاعي ان الكالبروتكتين النورمال فالي بتاعته بتبقى عالية قوي في الانفانس وطبعا في النيوبورن اكتر، ومفيش كات اوف بوينت عندها نقول ان ده اكشوال انفلاميشن. يعني ممكن ويل بيبي عنده مثلا شهر او شهرين يبقى النورمال فالي بتاعته مثلا 1000. ده نورمال في النيوبورن وفي السمول انفانتس. فالناس دايما بتقارن الليفل باليوجوال بتاع الادلتس او الاولدر تشيلدرن اللي هو مثلا في حدود 200. فدي نقطة مهمة جدا عشان يعني لو مفيش كات اوف بوينت واضحة مش هقدر نستخدمه كدياجنوزس اكيد لحاجة مهمة زي النيكروتايزنج انتيروكولايتس.
So it is still investigational test, and it
حتى
needs standardization, and it needs a lot of research. Okay.
حتى في كاوز ميلك الرجي وبيكون الطفل اوريدي عنده كولايتس وساعات يطلع نورمال. فهو الكورليشن بتاعته وحشه قوي في السن الصغير.
Yes.
والستادي دي يا دكتور كانت بتتكلم عليه في النيكوتايزنج انتيروكولايتس بس ما اتكلموش عليه، يعني اللي انا قريته يعني ما اتكلموش عليه في
Abdelrahman, also it is a test that indicates inflammation. It's not only neck.
اي انفلاميشن لو طلع
اي
عالي
انفلاميشن كده
It's for gut
يعني.
inflammation.
اوكي.
اتفضل.
الدكتور يعني من الكلينيكال براكتس بتاعنا we use the calprotectin in many cases. When it is less than 200, it indicates only feeding intolerance or prematurity. When it's more 200, 300, 700, this might indicate NEC. فيعني الأرقام دي roughly كده من الكلينيكال براكتس
حضرتك
بتاعنا
based on what
للكالبروتكتين.
دكتورة مروة based on what on
Based
clinical
on
experience
only clinical
or
practice.
on
On
ref
clinical experience. On
sorry
clinical experience and follow-up of cases. Clinical experience and follow-up of cases.
so it's a very good point for a clinical research, Dr. Marwa. You can give it like for a master degree, for a thesis, and you can have your guidelines and your standard numbers, which will be very, very helpful. Because clinical experience is good, but it is not enough to discuss like in an international conference or what in a journal, or you know what I mean?
تمام يا دكتور.
Yeah, you can
Thank
give
you.
it as you can start as a thesis for master degree, a good topic.
هو
Okay.
محتاجين الأول اللي احنا نعمل يا مروة مثلا شغل هنشوف ايه النورمال كالبروتكتين في سامبل كبيرة من الأطفال اللي هم النورمال في نيو بورن
Healthy,
مثلا،
healthy norm.
Yes.
وبعد ما نحدد
Yes.
الفاليو في ذيس ايج يبقى نعمل مثلا في
This will be
الهيلثي.
the control. Yes, this will be the control.
لأن احنا أصلا ما عندناش كنترول.
Yeah, the
تمام تمام.
control will be the healthy
فعلا.
baby, and
Yeah.
the sample, the targeted sample will be the sick, and you can select NEC, you can select cow milk protein intolerance, you can select other inflammatory processes in the GI. It's a very, very good field for
تمام.
research.
تمام. Thank you دكتور.
Okay.
And by the way, Dr. Amaran, is it a send out or you do it in
Actually,
Sharpie?
going to emit.
You do the test in Sharpie,
Unfortunately, it's not available.
لا outside.
It's not available.
and how much time does it take to get the results back?
2 to 3 days.
Yeah, which is not fair, especially in neck. It's not fair at all.
Yes.
Okay, keep going, sir.
Next, we'll talk more about imaging
Yes.
after lab investigations. The first look بتاعنا will always be an abdominal standing X-ray. When to use it in a sick neonate, suspecting the neck obstruction, perforation.
Standing? You said standing?
An abdominal standing X-ray.
Standing?
It's not standing in the common way standing, just the baby is erect.
We don't do for newborn babies standing X-rays.
Erect, I mean erect.
Not erect. They lie supine, and you can move them on either side. And this is the only way for Dr. Ahmed to have.
In our practice, doctor, we prop them up against the X-ray film.
You don't have the X-ray under the bed, in the bed under the baby?
Under the baby? No.
Yes, this is the portable X-ray, the digital one. You have the film under the baby, and the load ray coming from above.
No, when we're looking for perforation, we usually prop the baby up against the X-ray, and we have a standing, like we hold them.
You do Q lateral Q. Dr. Ahmed, what do you think? Do you make the babies stand up?
هو صعب بس يعني هو دايما اتعودنا ان هو يعملوا كده فعلا في النيوبورن، يوقفوا البيبي كده وبيتشال من كتفه وبتصور، وده غالبا بيبقى مطلب مهم جدا للجراحين كمان.
I have been doing X-ray for hundreds of years now for newborn babies, and usually the baby lies down supine or on one of the sides, and then the film is under the baby, and the cathode ray comes from above. I don't know. It's maybe this is whatever. It's something technical, but
Oh.
it's up to you. Keep going.
It's informative, to be honest.
Huh?
ماشي. The key features we're looking for, nematodes intestinalis. We also looking for fixed loops or dilated loops. We see these with the serial X-rays, not on one X-ray. Also, if there's perforation, there's going to be free air under the diaphragm and portal venous gas. These two pictures here, the one on the right shows air under the diaphragm. It's very apparent. And the one on the left, if you can see these black arrows here, I don't know if it's clear or not. This is nematosis intestinalis right here.
Usually it shows up like a honeycomb appearance in the wall, or a rail, or like a double wall appearance. This is how the nematosis shows up.
Here, I can see the honeycomb here and here, but I'm not sure if it's clear to everyone.
Yeah, but you could have a better X-ray than this. It's either the honeycombing or the double wall appearance because of the air, linear air shadow inside the wall of the gut.
Also, we've recently started using ultrasounds to
ultrasound.
It's very useful.
Yes.
We use high resolution transducers with the 8 to 15 hertz frequency. Higher frequency will give us usually better resolution for superficial interstitial bowel, and we visualize the individual bowel walls a lot better. We look for peristalsis, vascularity, the wall. The protocol used is the Feingold protocol. It was developed by Dr. Mary Feingold in Eastern Ontario. He divides the abdomen into 4 quadrants. Just to show us better. We divide the abdomen into 4 quadrants: right upper, right lower, left upper, left lower, and in each quadrant we look at the color Doppler. We look for peristalsis. We look for the thickness of the wall, and we look for the texture. What we're looking for bowel wall thickness. It could be thickened. That's a sign of early inflammation. It could be thinned. That's a very alarming sign. Could be we're going more towards the perforation. We look for peristalsis. In our humble experience, when we don't see peristalsis, that indicates very, very poor prognosis. Pneumatosis intestinalis is also apparent on ultrasound, portal venous gas, free fluid, the Doppler.
So pneumatosis should come as the first one. Okay, or maybe after the wall thickness or wall thinning. Yeah, but it definitely before the reduced peristalsis, because this is a late sign.
This is not in order of severity in any way. Okay, now we have these two pictures. The one picture A, this is the normal bowel. We can see the normal thickness of the wall. We have the normal thickness of the wall right here. We have a double lumen wall. We have this normal thickness. In the board, we have another lumen. These small artifacts, these are like artifacts from the stools in the gut. On this side, we have the Doppler. This is what we call a speckling appearance. This indicates normal perfusion to the gut. Here we see 2 findings. You can see this bowel loop here. And this is the other end of the wall. We can see a very thickened bowel loop compared with the one before. And here, a very, very thin bowel loop on the one on the right. Okay, you can barely see how thin it is. Doppler findings. And this just shows bowel thickening. These folds are thickened edematous. And here we can see the zebra signing and the Y signing. I don't know if this is a Y and it's a zebra, I think it's. Pneumatosis intestinalis. It's obvious in the wall. You can see here. There is air in the wall in the intestine. And we move on to contrast studies. Contrast studies we usually use with malrotation with volvulus. Upper GI contrast shows the classic corkscrew appearance. Or we do it with suspected atrasias, duplication cysts, really any anatomical concerns here. It's very invasive and it carries a risk of perforation.
So if you have volvulus or malrotation, what do you see in upper GI?
We see this image right here, Doctor. We see the corkscrew appearance.
And what else? There is a very important sign by X-ray, and there is another one by ultrasound.
I'm not familiar with the other signs. We usually, like the
the-
first line is upper GI.
The duodenum does not cross the midline. It's all on the right side. And then when you do ultrasound, you will note that you look at the relation between correct me, Dr. Ahmed, because I might have forgot, the splenic artery or splenic vein. Is it that?
نشوف الالترا ساوند.
Yes.
لا ما عنديش اكسبيرينس صراحه في
لا.
التشخيص
This
بالاسلوب
is
ده.
more easy to interpret يعني.
There is a very good sign by ultrasound, which is the correlation between the artery and the vein. And you can look for it and you can see if it is which artery and which vein. This is diagnostic.
Okay.
Okay.
Next, we're moving on to management. Management always starts with the ABCs. We always have to look at the airway, breathing, circulation, assess everything, and resuscitate if needed. You can give IV fluids if the baby is shocked. You can even intubate if they're distressed. Depends on their clinical condition at presentation. After the baby has been examined, resuscitated, or
So
otherwise
if you
he's healthy.
divide your management items,
نعم.
what are you going to, what are the main topics? Like number one, assurance, no treatment, correct? Number two, observation. Number three, medical treatment. Number four, endoscopic management.
We're
Number
coming up to
five,
this.
surgical management. These are the items. Okay?
Okay. Medical management. تمام. Of course, if it's swallowed maternal blood or otherwise, it will be reassurance. But in medical management, we usually, if it's cow milk protein allergy, we'll usually give an extensively hydrolyzed formula or an amino acid formula, or we'll ask the mother
Give
to.
me an example of the casein hydrolyzed formula in the market.
The amino acid formula, Neocate.
I said casein hydrolyzed because the amino acid formula is they are two different categories.
احنا يا دكتور ايهاب في مصر ما عندناش غير امينو اسيد بيزد فورمولا.
ما عندكوش
ما عندناش اي نوع
Regispril or Nutramigen or
لا ما بينزلوش مصر لا.
Okay, so you have only the amino acid which is Neocate.
نيوكيت عندنا نيوكيت سينيو ونيوكيت انفانت، لكن ما عندناش اي صوره من الاكستنسيف ادلايز.
Yeah, we have here both formulas extensively hydrolyzed, which is the casein and whey protein hydrolyzed, and you start with them, and if not successful, you go to the amino acid formula, and the only one I know is the Neocate. Okay, keep going.
هو ده الجايد لاينز، بس احنا هنا في مصر بقى بنضطر نسكيب الخطوه بتاعت الاكستنسيف ادلايز لان من 2011 وما فيش عندنا غير النيوكيت بس.
Okay, good, no problem.
With breastfed, we do elimination, and then we re-challenge after 6 weeks. Anal fissure. If you diagnose anal fissure, you give barrier creams. You can give laxatives if there's hard stools and constipation. Increase hydration intake.
What is the best barrier cream?
No, I'm not familiar with brand names.
Zinc oxide. Zinc oxide. And then you use this PEG 33-500 if there is constipation. What is the other name for the? What is the? You are challenging.
اسمه ميرالاكس او موفيكول.
PEG, I think it's abbreviation for it.
بولي إثيلين جلايكول.
Yes, sir. Yes, sir. Okay. Yes, we know about NEC. Yes, how to treat.
We follow the modified Bell staging criteria. It also gives treatment recommendations. As we said, with vitamin K deficiency, we give vitamin K. Stress ulcer, we start IV PPIs. And if there's constipation-induced...
Please get rid of consider fresh frozen plasma in case of vitamin K deficiency. Please, the treatment is vitamin K.
Sometimes if there's severe ongoing bleeding, we don't have the concentrates available. We're forced to give fresh frozen plasma.
We don't have, what do you mean by concentrates?
Coagulation factors, I mean.
But there is, it is vitamin K deficiency and not coagulation factor deficiency. So you don't give cryoprecipitate or concentrate unless there is factor 8, factor 9, von Willebrand disease. Don't get confused, please. Vitamin K deficiency, the treatment is vitamin K. And of course, A, B, C, D. And this, there is coagulopathy and factor deficiency inherited. You give, and you don't have the factor, you give fresh frozen plasma. Okay, sir?
Okay, sir. If medical management fails and the baby is continuing to deteriorate...
Please, Dr. Ehab, I want to comment.
You skip? Yeah, go ahead, Dr. Amana.
Dr. Abdelrahman, I want to ask you an important question. If you face a newborn with vitamin K, with BT and BTT prolonged, it seems it's like vitamin K deficiency, and you give vitamin K in therapeutic dose 1 day, 2 days.
Dysfibrinogenemia or some other problem.
Sorry?
It could be some other problem. It doesn't have to be vitamin K. It could be dysfibrinogenemia, afibrinogenemia. There is other causes that cause prolongation of the PT and PTT and INR.
Yes.
Yes, go ahead, Dr. Amanal. I'm sorry.
I wanted to highlight an important disease present, وممكن أنا أحكي story I faced this disease وبصراحة I learned from this disease. When you give vitamin K to an infant or newborn and not responding to vitamin K, therapeutic dose of vitamin K, you should first use, as Prof. Ehab said, for other causes. And if you find no other causes and there is no response to vitamin K, you should think it is liver failure, right? Right or not? جاوب يا عبد الرحمن.
Say it again.
هو definition. Definition of liver failure.
Okay, liver problem, yes. Yes. Coagulopathy secondary to liver failure.
Yes. INR, definition of liver failure. INR alone, you can diagnose liver failure alone by INR more than 2 seconds, or INR equal to or 1.5 with encephalopathy. In this case, INR will be all the time 1.5, 1.6, 1.7, but there is no encephalopathy. The only pathology present is prolonged BT and BTT and not responding to vitamin K. حلها عروست.
Yes. From my experience, Dr. Manal, I saw exactly this scenario and proved to be dysfibrinogenemia.
Okay.
And now you say it's liver failure or coagulopathy secondary to liver disease. Yes. Look for other causes.
Another important cause for the liver it is inborn error of amino acid metabolism, which is tyrosinemia.
Yes.
And please think for tyrosinemia بتدوخ الناس كلها وبتدوخ الهيماتولوجيست ويقعدوا يعملوا في كل coagulations factor وما تطلعش ويبقى التيروزينيما تايب 1 اللي هي احنا بنسميها هيباتورينال بيبقى فيه ليفر افكشن بيبقى فيه RTA والليفر بيبريزنت نفسه بعد كده بليفر سيروزس. فبليز think for tyrosinemia in any newborn with signs of vitamin K deficiency and not responding to vitamin K in therapeutic dose and not in liver failure. Thank you.
Yes.
هيكون معانا other signs of liver dysfunction ولا coagulopathy بس؟
في
It is
البداية
just
في البداية ما يبانش، في البداية ما
is
يبانش. أيوه بالظبط
but
كده.
it will prove itself later.
يس طبعا طبعا بيفضح نفسه، بيكشف نفسه بعد كده تماما.
Yes.
وليتر مش ليتر كتير يعني دكتور إيهاب، لا ده يعني في خلال 3 to 6 months يعني يبان بقى كل
Yes.
المانيفستيشن بتاعت الليفر فيلير. احنا اول ما فيسنج الحالات دي طبعا ما بقيناش عارفين لغايه لما يعني في حاله دلوقتي هي بريزنت بار تي اي، واحنا شاكين ان هي تيروزينيميا، وبتعمل بقى الحاجات بتاعه التيروزينيميا، ساكسينايل اسيتون ان يورين، وبلند فور ليفر بيبسي، بلند فور ليفر بيبسي ان شاء الله. فالتيروزينيميا او الانبورن ايروف ميتابوليزم انت دايما تفكر فيها لما بتلاقي الدنيا قدامك مش ماشيه كويس. شكرا يا عبد الرحمن.
Thank you very much.
You are welcome دكتور إيهاب.
ماشي. when medical management fails and there is uncontrolled bleeding, we can give considered IV bolus of proton pump inhibitors, and then we switch to every 12 hours. Clinically significant bleeding, we have to follow goal-directed transfusion protocol. We have to look at our hemoglobin. We can give packed RBCs if needed. We can give platelets as
Yes,
needed.
but
We give plasma as needed.
بالنسبة hemoglobin, when you follow up hemoglobin and when you follow up blood pressure, there is some important points. The
It can be
hematocrit,
misleading.
is the least to be affected, and it needs either a very massive bleed or some time. Because if the hematocrit is like 43, okay, and the baby is bleeding, he's bleeding whole blood. So the same percentage of red cells still there in the blood. So it will not drop because there is also some compensatory mechanisms, or when you do fluid resuscitation, or if the bleeding is massive. This is important point. So don't get confused. You say, oh, the hematocrit didn't drop much, so the bleeding is not serious, or it is important point. Another important point is blood pressure. The blood pressure does not drop early in neonates who have hypovolemic shock. It needs time. The first sign is tachycardia. And if you wait till the blood pressure drops, meaning the baby is very, very late. The baby is in a serious shock. You have to interfere. Don't wait for blood pressure to drop. This is two important issues when you evaluate the baby: following the blood pressure, following the hematocrit. Okay?
Okay.
Keep going.
Last point was considering IV erythromycin pre-endoscopy. Endoscopy. We don't usually do endoscopy in the NICU, but for more logistical reasons than anything else.
Dr. Ahmed, do you do endoscopies in the newborn babies if they are having a GI bleed or not? You need your experience.
هو يعني اكسبيرينس مع زمايلنا، هو ما بيطلبوناش نعمل مناظير غير يعني فيما نقدر. بس احنا عندنا النيونيتوسكوب، يعني تكنيكالي ما عندناش مشكلة. بس هما غالبا يعني بيشخصوا بقى، فما يحتاجوش يعملوا diagnostic endoscopy.
Although it is not, we don't do it initially or in the first steps, but at some point, endoscopy plays a role, either in the diagnosis or in the management.
أكيد.
And part of the management is to do submucosal injection of epinephrine.
لو في ulcers لو.
Yes, this is part of the management. Or sometimes, if there is a bleeder, because of malformation of the blood arteries or whatever, you do injection of a sclerosing material. I know this is extremely rare.
يعني انا عملت غير مره واحده بس في 10 سنين فاتوا. عملنا منظار قبل كده لطفل عنده 6 ايام.
And it should be done by the pediatric gastroenterologist, and preferably who has experience with the newborn babies.
احنا عندنا 5.5 مللي اللي هو ممكن نستخدمه في اطفال عندهم مثلا 2 كيلو 2 كيلو ونص.
Yes.
هو بس مشكلته ان هو الاونلي انترفنشن اللي ممكن نعمله بيه هو الانجكشن. ما بيديناش يعني
Yes.
ما بنقدرش نعمل بيه اي ثيرابيوتيك انترفنشن اكتر من انجكشن، لان الشانل بتاعته بتبقى يعني فيري نارو 1.8 مللي.
Yes. Yeah. There is a lot of debate about the use of endoscopies in the GI bleed in the newborn. So you are right, sir. You are 100% right. Thank you very much.
ثانك يو. هو بس الريسك بتاع البرفوريشن يعني انا شايف عبد الرحمن كاتب ان هو كاتب ريسك برفوريشن 5%، ويعني objecting this huge number يعني
You mean with the scope?
5% برفوريشن ريسك ده يعني عالي قوي، الا مثلا لو غلطنا ودخلنا في عين عنده نيك مثلا، لكن في اي تشخيص تاني صعب قوي يحصل برفوريشن.
الفيجرز دي يا دكتور انا جايبها من الاي اي بي نيو ريفيوز. دي الفيجرز بتاعتهم هم. فانا
مش عارف، بس يمكن قصدهم بقى لو عملوا كولونوسكوبي كمان يعني، لكن اعتقد يعني لو جاستروسكوبي او ليميتد كولونوسكوبي
ما حددش
برفوريشن
بالظبط،
قليل
كان
قوي.
بيتكلم على الاندوسكوبي ان جنرال، ما دخلش ان ديتيل بالظبط كان ايه البروسيجر اللي بيعملوه.
مش
Yeah.
عارف بس يعني هو اصلا الريسك برفوريشن في الكولونوسكوبي يعني اقل من 1%، والبرفوريشن في الجاستروسكوبي اقل من 1 في الألف. مش عارف الارقام دي ليه عاليه كده.
Yeah.
ممكن الاكسبيرينس بتاعهم هم بقى.
It
احتمال
depends
بقى.
on their experience.
اه
Yeah, but okay. Thank you.
هم برضه دكتور كانوا قايلين برضه ان هم الدايجنوستيك ييلد بتاعهم هم لو، يعني هم بيقول لك هم يعني whenever they scope a patient usually they don't find the source of the bleed.
عشان هو معظم الكوزس بتبقى سيستميك او نتيجه يعني لوكال كوزس، زي مثلا كاوز ميلك الرجي ما بتحتاجش تعمل له منظار، فعشان كده اليلد بيبقى مش.
Yes.
وبعدين كمان حاجه تانية، الاندوسكوبيك فايندنجز في الاطفال الصغيرين ما بتبقاش يعني ايفيدنت او واضحه او سيفير زي ما الناس متعوده تشوف في الادلتس، تبقى كلها ماينيوت بليدنجز يعني ماينور انفلاميشنز، لكن مش هتلاقي يعني حاجات ميجور.
Abdelrahman, before you finish, I need you to stress on the stress ulcers, because maybe we underestimated or underdiagnosed it. Do you
Stress
have
ulcers?
any comments about that? Stress ulcers.
We talked about stress ulcers. We said stress ulcers to suspect it when we have hematemesis in a very sick neonate, post-operative, very significant hypoxia, ventilated.
HI is a very major cause. So, do you need to scope them?
No.
Okay. How you treat them?
We give IV PPIs, IV proton pump inhibitors, until we stabilize them best, and then we can move on from there بعد كده.
Okay. Okay. But you should know the hazards of the PPI when you use them, and you have to use them cautiously and not for a long time. Okay. Thank you very much. Keep going.
Sometimes, unfortunately, we have to resort to surgery. Not commonly, but sometimes we do. We usually refer to surgery if there's a refractory bleed, it's refractory to medications and refractory to endoscopy. Patient is unstable or ischemic. There's an ischemic gut, example neck with perforation. The procedure is usually an exploratory laparotomy, and they do vessel ligation, resection. Usually the patient comes back with a stoma. This is the end of our talk. We just have a few MCQs just to refresh everything and drive home the points. Everyone can write their answers in the chat برضو. A well-appearing term neonate on day 2 presents with a single episode of hematemesis. Vitals are normal. What is the most appropriate next step? Easy.
Abdelrahman, كل الأسئلة بتاعتك the answer is C.
بلعب على الجانب
Why is
النفسي.
that?
لازم تبقى خادع شويه.
ما بحطهم كلهم سي عشان الناس تشك في نفسها شويه.
لخبطهم يا أخي. اوكي.
على فكره بس عاوز اقول ان الابل تيست مش موجود عندنا في مصر.
لا،
لا ازاي يا دكتور، احنا
مش موجود.
هو
I
ما
thought
اعرفش،
it's very
ما
simple.
طلعتوش بقالي فتره، بس انا
لا
كنت
مش
عملته
موجود
في اول
خالص.
نيابتي.
لا مش موجود خالص دلوقتي.
I thought it's a very simple test. سبحان الله.
اه
Yeah, you have to use your clinical sense بقى يا عبد الرحمن.
مم.
Okay.
ماشي. next question. Uh, a preterm neonate on day 6 of life has recently increased enteral feeds. The baby develops mild abdominal bloating and passes a small amount of blood-streaked stool. Vitals are stable. Feeding intolerance is minimal. Which investigation is most helpful at this stage to support early diagnosis?
I would like to know how many weeks this baby is.
Preterm.
This could be from 22 weeks to
خلي بالك انت بنفسك
36 and
قايل
6.
انت بنفسك قايل الاسبوع الثاني والثالث.
ما حبيتش صعب بس يعني.
Okay. So انا هروح لسي على طول من غير ما اعرف اقرا
من
الحاجات
غير ما افكر عادل.
زي ما اتعودنا طبعا.
سي.
اه اللي بعده. A 5-day all-term infant born at home presents with blood-streaked stools and mild oozing from the umbilical stump. The baby is otherwise well and feeding normally. Which of the following lab findings would most support the likely diagnosis?
حاجه غريبه، ما طلعش سي المره دي.
المره دي والسياح.
انت بتلخبطنا كده يا عبد الرحمن.
في الآخر بقى. تمام، أغلب الناس جاوبت صح. دي prolonged PT PTT ونورمال platelet count عشان بندور على فيتامين K.
عبد الرحمن عاوز اسالك على سؤال. لو السيناريو
اه
اللي فات ده كاوز ميلك الرجي، يعني مفيش امبلايكال بليدنج وهو
مم.
جايب بلاد ستريك كده في الستول، هل
مم.
ممكن هو عنده 5 ايام يبقى كاو ميلك الرجي؟
ممكن.
ممكن بس فيري انيوجوال، يعني يمكن اصغر
تاخد
حاله
وقت،
شفناها 3 اسابيع 4 اسابيع
تاخد وقت.
يعني.
انت نفسك قلت كده يا عبد الرحمن والله. if you review your slides هتلاقيك كاتب كده.
كاتب
يعني
ايه؟
انا ما
اللي
شفتش غير
هي
مره واحده بس
انت
طفل
نسيت.
عنده بليدنج وهو عنده 5 ايام طلع ميلك الرجي.
يس.
يعني لازم يعدي اسبوعين كده قبل ما يحصل سنسيزيشن وانفلاميشن وكولايتس تتساب من غير تشخيص فيبدا يظهر بلاد، يعني ما يلحقش
هو
يحصل في
انا
5 6 ايام.
لما كنت بقرا صراحه دكتور في الموضوع، يعني كان قالوا ممكن، بس قالوا uncommon جدا يعني في نفس
اه
الوقت يعني.
Yeah. Okay.
MCQ number 4. Which is the most appropriate statement regarding nasogastric aspiration in neonates? كويس، اغلب الناس جاوبت دي، كويس. مختلفه
بص يا عبد
برضه.
الرحمن، بالنسبه لموضوع ان جي انا
مم.
انبسطت قوي ان انت يعني وضحته قوي، لان انا من زمان قوي قوي من 2011 من ساعه ما رجعت من كندا، وانا كل ما اقابل النواب في البطنه او في الجراحه اقول لهم بلاش نعمل ان جي يا جماعه. وبعدين ما اعرفش واضح الموضوع يعني يعني لازق في دماغ الناس كلها ان لازم نعمل ان جي، يعني ووش في اي طفل عنده هيماتيمسيس. وتلاقي مثلا نايب او دكتور امتياز يقول لك عشان اتاكد ان هو عنده هيماتيمسيس، فهو اللي بيرجعه من بقه ده ايه؟ يعني ما هو هيماتيمسيس، انت عاوز تشيك على ايه؟ يقول لك عشان
ده
اتاكد.
عيب الكلاسيكال تيتشنج القديم خالص.
يعني دي نقطه متوارثينها. الواحد اخذ وقت كبير جدا عشان يحاول يقنع الناس، لدرجه ان انا في فتره من فترات قلت لو حد من النواب عمل ان جي ووش يعني اي ويل بانش هيم.
صدقني يا
فاتبسطت
دكتور
بقى
ممكن.
لما انت وضحت بالايفيدنس ان هي خلاص ما بقاش رول دلوقتي فعلا،
اه لا،
يعني ساعات
discouraged
كتير
جدا يعني.
ساعات كتير الطفل يكون عنده بليدنج بوينت واوريدي بدأ يعمل يعني بلاد كروت عليها وهتقفل خلاص، يجي الوش بقى يعمل لها ريموفال وتحصل بليدنج جديد.
او تعمل تروما جديده وانت داخل اصلا.
ممكن.
آخر واحدة خلاص. A term neonate has streaks of bright blood stool bright red blood on stool, the baby is otherwise well. On examination, a peripheral crack is noted, perianal crack is noted. What is the most likely diagnosis? سهلة دي. اوكي دي سهلة واضحة.
انت
اخر
عارف
حاجة
المشكله
خالص
في الانال فيشر ايه يا عبد الرحمن؟ ان الناس
دكتور؟
فعلا ما بتعملش اكزامينيشن
بتبص.
وتاخد وقتها ان هي تشوف كويس، فكتير جدا ما الانال فيشر ما يتشافش، هو محتاج ان انت تفحص كويس، تعمل سبريد عشان تشوف الميكوزا كويس. الناس بتبص على السكين كده من بره وخلاص.
ما حصلت معانا من قريب حتى، يعني كنا طفل 5 ايام ومشينا معاه في الورك اب بتاعنا، وكنا خلاص وصلنا ان احنا هنقول ان هو كوميك يعني بروكتوكولايتس يعني، ومحدش كان بص على على الانس. فاول ما بصينا على الانس لقينا الفيشر يعني على طول، يعني كنا بدينا نقول ايه ده ايرلي جدا انه كان جاي عند 5 ايام. ففعلا مست بطريقه يعني كبيره جدا يعني. التيك هوم بوينتس الاخيره بتاعتنا ان احنا بس not all bleeding in neonates is dangerous, many are benign and self limited. بس ده مش معنى ان احنا نignore it او نتهاون بالكومبلين. Always assess if the baby looks well versus unwell. This determines your urgency. The most important point زي ما دكتور ايهاب قال، ما نستناش البلود بريشر يقع. Examine both the infant and the mother. Swallowed maternal blood is common. المother هنبص على البريست ونبص على النيبل وندور على النيبل cracks. swallowed maternal blood, fissures and common nicotine allergies دول top benign causes. Neck, volvulus and stress ulcers present with sick neonates، في الأغلب بيكونوا unstable فلازم نأكت fast. الفيتامين K deficiency ممكن يبريزنت في well baby، ممكن يبريزنت بس يعني quickly deteriorate لو developed intracranial hemorrhage، ف treat immediately if suspected. طبعا a structured stepwise approach لازم نبقى focused عشان ن prevent over treatment أو under treatment لأي حاجة. وشكرا.
Thank you, Abdelrahman. A very good presentation, a very good job. You
شكرا
did
حضرتك.
a very good job and you did a very good effort and appreciated. And I believe you are going to be our reference for GI bleed in the newborn baby. Your lecture will be our reference. Thank you very, very much. دكتور أحمد، حضرتك تحب تضيف حاجة، تعمل كومنت، تصلح لنا حاجة؟
لا، هو فعلا زي ما حضرتك قلت المحاضرة معمولة كويس جدا، وماشي سيستميك ده في الكوزس، وعمل إليبوريشن كويس، فممتاز جدا صراحة، يعني تسلم
شكرا
ايده.
حضرتك دكتور. شكرا حضرتك دكتور.
Very much. For everybody in the meeting, if you have any question, any comment, any correction, whatever, please go ahead. Yeah, go ahead. I will try to see what is that in the chat. جزاكم شكرا. Thank you. No questions, no comment, no query. Thank you. Many thanks. I don't see any questions or comment. Okay. Thank you, everybody. Appreciate Abdelrahman. Thank you. Dr. Ahmed, thank you very much.
شكرا دكتور إيهاب، شرفنا بحضرتك.
With us many times in the future. We need your expertise, your area of expertise, and you are definitely you reached our discussions.
شكرا جزيلا، تحت أمر حضرتك في أي وقت إن شاء الله.
Thank you very much. Dr. Manal, thank you very, very much for attending. And we had very, very good comments, actually. Thank you very much. Inshallah, next Saturday, I'm going to talk case discussions in newborn infants, MCQs, index of suspicion, visual diagnosis. And then the week after that, inshallah, we are going to present fluid and electrolyte management in the newborn infant. And I recommend that every and each neonatologist and pediatrician taking care of newborn babies to attend. This is extremely important practical issue that will affect our practice. So please attend this meeting, and thank you very much. And inshallah, see you next Saturday. شكرا يا دكتورة مروة، دكتور أحمد،
شكرا جزيلا.
شكرا يا دكتور.
and Dr. Abdelrahman and Dr. Ahmed Fouad. Thank you very much, and Dr. Rahman. Appreciate it. Take care. Bye bye.
مع السلامة. مع السلامة.
شكرا لحضرتك دكتور إيهاب، سلام عليكم.
Thank you
جزيلا.
very much.
شكرا لحضراتكم جميعا.